that I could start from the point that Brian left. My city, Bologna, is on the back. You see, this is a beautiful view of my own town. I like it as well, like Brian. I agree with him that this is not the right moment to visit it, but if you have a little bit of time in the future of your life, please to come. For those of you who don't know, this is a marvelous, very old city. But I also starting from the point that Brian left in terms of blood pressure control. This is my conflicts, potential conflicts of interest. In terms of blood pressure control, since we know very well that despite more than 50 years of active research in hypertension, the extent of blood pressure control in the population is pretty much under expectation. That is true for the industrialized countries, like Brian has clearly shown in this outstanding opening, but is even more evident in the low-income countries. This can be done, what could be the consequence of many different factors, or the failure in the way of management of hypertension. In the next 20 minutes, or maybe something less than 20 minutes, I would like to review with you some of these problems, taking advantage of the opportunity to share the many options that comes out from the analysis of a typical clinical case of a patient with a poor controlled hypertension. This is the patient. The Dr. Gashen means that we are talking about something we have to decide together. Of course, is a female patient, 63 years old, you see, with a blood pressure and the declared poor adherence to the antihypertensive treatment. She said he doesn't like to take drugs. She's currently treated. We have so many of these patients in Italy. I really don't know which one is the experience all over the world, but we have so many of these patients that say they don't like to take drugs, any kind of drug. She's treated with low dose of an ACE inhibitors, and from the family history, she has a positive family history for hypertension, quite a sedentary lifestyle, just a few cigarettes a day, and nothing more in terms of personal lifestyle. As far as the physical examination, you will see she is a little bit overweight with an abdominal circumference which is above the one suggested as normal, and the blood pressure is absolutely out of control. From the general examination, nothing special, and at the echocardiogram she has an initial left ventricular hypertrophy that suggests the presence of a target organ damage. So actually it seems to be the typical example of a patient with hypertension and overweight. But if you look at the laboratory profile, you would see that hypertension and obesity is pretty much integrated by some additional lab information that focused on the abnormalities of the serum glucose and some abnormalities in the lipid profile, and maybe some evidence of target organ damage even at the kidney level. So basically what we are talking about is a typical case of patient with hypertension and the metabolic syndrome, which according to guidelines belong to the high risk categories. So a patient in which we have to treat effectively hypertension and all the other risk factors for cardiovascular disease. So bearing in mind this few information that briefly describe the case, let's move on to the first question I would like to ask you. And the question is, what antihypertensive strategy could represent the most reasonable choice for this patient? Wait and see. Just look what's going on with blood pressure, change the monotherapy that the patient is currently taking, manage the adherence to treatment, increase the dose of the ACE inhibitor, or combine the current treatment with a second antihypertensive drug. Now you can vote to your cell phone. You have a very technological system installed in your cell phone through the app. When we are talking to the app, we should ask to the master of the app, Professor Parati. He is responsible for all the apps we have in this meeting. I'm waiting for you, and then after that we can try to discuss your suggestions, and I will try to share it with my point of view, And finally, we will have a general discussion on how to manage this case, which is a pretty simple, I think, from the clinical point of view, but is a typical case of decision-making. That's enough? Let's see what's going on. Now, the adherence and the second drug. Okay, let's move on. I will try to, of course, to manage, to discuss with you what's going on. Certainly, we don't have to wait and see. This was my personal decision, but of course, it's pretty much close to the one you have suggested. Of course, we don't have to wait and see because, as already pointed out by Brian, the therapeutic inertia is a big problem now. It is probably responsible for the poor blood pressure control. And you would see from this paper, which has been published some years ago on the Journal of Hypertension, there is a lot of our colleagues that are not considering that elevated blood pressure values should be enough to increase the antihypertensive treatment, and additional changes in antihypertensive treatment are usually taken into account only for patients with very high blood pressure values. So of course we don't have to wait, we have to treat this patient, considering that according to Brian's introduction, hypertension is not an opinion, it's a big problem, it's a problem associated with a very high risk of cardiovascular disease, and in particular if you look at the literature you would see that some kind of regression toward the mean of the blood pressure values can be found in a population less than 15% based on the first diagnosis. This is not true, of course, for the established hypertension. So the first answer, absolutely wrong, and we have to treat this patient. The second point is change the type of monotherapy. Why? There is no reason. ACE inhibitors and drug inhibitor in the renin-angiotensin system are pretty much recommended by the guidelines as the main treatment for patients with hypertension complicated by metabolic syndrome or abnormal metabolic profile. So I think that you have been right when you have suggested this one as a possible solution. Adherence. So this is a very important problem. You know very well that adherence to treatment is pretty low. It decreases very rapidly in the hypertensive population, and even better, even worse if you combine the poor adherence with a poor persistence of treatment. But anyway, what is important in this case is that, of course, we have to manage adherence, but we have to manage it, not just to promote it. Because if we just promote adherence as a general concept, I think that the result would not be very good. According to this nice presentation, this nice meta-analysis published on the British Medical Journal early this year, and showing that if you put together all the studies in which adherence has been promoted through a different tools, the overall improvement in terms of blood pressure control is absolutely under the expectation. What about doubling the dose of the ACE inhibitor? It could be a solution, of course. The drug is good, it's working very well in this patient, not enough in terms of blood pressure control. One idea could be to increase the dose of the ACE inhibitors, but we have the results of studies like this one showing that you can achieve even better results in terms of blood pressure control if you add a second drug instead of doubling the dose of monotherapy. And this probably is the case of this patient. And in this patient, I think the best solution is the one that most of you have chosen. So it was going to a combination treatment, moving from monotherapy to combination treatment. This is pretty much endorsed also by guidelines. The guidelines actually suggest not only that combination treatment should be used in patient poor responders to monotherapy, but also that the combination treatment could be the starting treatment in very high-risk patient, as could be a patient like this. So later on we can try to discuss if the combination treatment would have been for this patient the first choice, and I think yes. So the first decision was go to a combination treatment to improve the blood pressure control. Now you have to have your cell phone in your hands to be ready to answer to the second question. Let's say, provided that we have decided to go recombination, how to maximize the expected clinical benefit of combination treatment. We can add any other blood pressure lowering drugs to ACE inhibitors, or we can add a specific class of drugs. We have to consider of giving the combination as a free drug combination, just adding a second molecule, or we could have a most comprehensive choice, or giving to this patient a single pill combination with multiple drugs. Now you can vote again. The first vote was pretty much successful. It was in line with what we expected. I don't know what the chairman think about that, but we will discuss at the end of the meeting. But basically, I think it was our patient could be very happy or having such a huge amount of doctors taking care of his health and the blood pressure control. I think nobody has ever had this kind of privilege. Wonderful. D, consider a single pill combination. I definitely agree with this point of view, but anyway, I would like to go through some of these possible answers, just try to support why the 4 is the right answer. First of all, add any other drug. It could be, in general, a good choice, because when you use 2 drugs instead of 1, usually you have an improvement in the blood pressure control. But basically, if you look at the results of clinical trial, it's not my personal opinion or the personal opinion of the board of this meeting, but if you look at the results of clinical trial, you would see that when you are treated with an ACE inhibitor, like a patient like this, most of the results in terms of further improvement of blood pressure control and prevention of cardiovascular disease can be achieved by combining the ACE inhibitors with a calcium channel blocker or with a diuretic. No data on the combination with a calcium channel blocker with RBs, no, and while the extent of positive results with other combination of drugs are pretty low. So we have a specific indication on which drug should be combined with the ACE inhibitor in this patient. And in particular, this is supported by the European guidelines that again suggest that if you are treated with an ACE inhibitor, maybe the most reliable combination is with a calcium channel blocker or a thiazide diuretic. In this specific case, maybe the first choice would be the combination of an ACE inhibitor with a calcium channel blocker, not because I'm telling that, but because we have the result of the accomplished trial that seems to suggest that the combination ACE inhibitor and calcium channel blocker seems to be a little bit better than the combination with a diuretic in terms of clinical outcomes. So in this patient, I would go for this kind of combination just to improve combine the improvement in blood pressure control with the improvement in the clinical outcome. What is very important is that whichever is the solution, and I think that the solution is a combination of ACE inhibitor and calcium channel blocker, you should try to give these 2 drugs in a single pill. Giving the 2 drugs in a single pill means to significantly improve the adherence and the persistence on treatment. You will see how many different studies made in a very different population of patients seems to support this point of view. All of you is aware that the improvement in the adherence is not a cosmetic one. Very interesting, these effects in terms of improvement in the adherence has been confirmed also in the population in the real practice. This is a study we have just concluded, the paper has been submitted the last week, which is called the AMPERE study, in which we have taken in Italy a large population of patients already treated with a monotherapy with perindopril or amlodipine or a free combination of the 2 drugs, and they have been switched to the fixed dose combination of the same 2 drugs, and you will see that whichever was the starting situation, the use of the combination, the fixed dose combination of the 2 drugs was associated with a significant improvement in the adherence. And in our specific case, in the case of our patient, we are going to move from monotherapy with an ACE inhibitor to the fixed dose combination, and we would expect exactly the same result. And the same results means life, because if you look at the relationship between the improvement in the adherence to treatment and the clinical outcome, you would see, and you know very well, that as soon as the adherence to treatment is going to increase, there is a progressive increase in the reduction in the rate of major cardiovascular disease, which is pretty obvious, because you're achieving the same patient at the same time an improvement in blood pressure control and any other additional effect of the drug, which is usually not taken by the patient. So actually, I think we have already moved some very important step forward in the managing of this patient. Our strategy was just try to manage hypertension, giving the patient a combination of an ACE inhibitors and the calcium channel blocker as a fixed dose single pill combination. We stressed the importance of improving lifestyle, and at the same time, we treated the patient with a statin because he has some kind of atherogenic dyslipidemia, which is the one which is described in patients with a metabolic syndrome. What we achieved after 8 weeks was an improvement in blood pressure control, but it was, again, not satisfactory. Why? There was a significant improvement in the metabolic profile. So we have made some step forward. We are not close to the end of the correct management of this patient. So I need you again. I need your point of view. I need your support to manage this patient. I'm not able to do it. Even the chairman probably are not able to get the best solution for these patients. So there is another question. Which strategy can further improve the blood pressure control and the cardiovascular risk in this patient? The possibility you have just to enforce the lifestyle changes. And the second one would be we can add an alpha blocking agent. In Italy is very popular the use of the alpha blockers in all the patients in which blood pressure is not really well controlled. We could add a diuretic. We could add a beta blocker, one of the other first-line drugs, or we can propose this patient for the renal denervation because we consider that according to the poor response to treatment must be considered as resistant hypertension. You can vote now. The solution is C, and I cannot agree much more with you, and I think, but again, we can try to support this evidence. Of course, when you are a patient treated with the ACE inhibitors or a drug inhibiting the renin-angiotensin system and the calcium channel blocker, the next step would be a treatment with a diuretic. And just in honor of one of our chairmen, I've chosen the data coming from the NICE guidelines that clearly suggests that the diuretic is the ideal combination for patients already treated with the other two classes of drugs. In particular, in terms of clinical outcome, we have the interesting result of the Pianist trial in which a triple combination of an ACE inhibitor, a calcium channel blocker, and a diuretic has been used. But what is interesting from our point of view is that this solution has been achieved by starting from different combination of the previous drug, and you will see that among the combination there is also the one in which the patient was already treated with an ACE inhibitor and the calcium channel blocker, and even in this case the addition of a third drug, the diuretic, was followed by a significant improvement in blood pressure. So I think actually there are no other possibilities to manage these patients in a better way. What is important in terms of clinical outcome is to consider that this is a very special population of patients in which the abnormalities of blood pressure control are combined with a, let's say, negative, unfavorable metabolic profile. So when we manage the antihypertensive treatment, we also take care of the effect that the antihypertensive treatment can have in terms of metabolic profile, particularly when we manage a diuretic. And you know very well from the literature, this is a huge review coming from the Cochrane organization comparing the metabolic profile of the different possible diuretics, and you would see that the better diuretic, the better profile in terms of metabolic control is certainly the one that you can achieve with a so-called thiazide-like diuretics, and in particular the one with indapamide, who has a better effect in terms of control of serum glucose, potassium level, and changes in serum uric acid. And maybe some of you knows how interesting is for me the changes in the plasma level of serum uric acid. So basically, what we did as a final follow-up, we added a diuretic as a fixed dose combination, single pill to this patient, and what we achieved was an improvement in the blood pressure control, pretty much close to the guidelines, an improvement of the lipid profile. The patient reported that she has improved its adherence to treatment, and we have to think about that it was true, and also she had a better physical fitness and a better lifestyle. So this is my last slide. We can try from this case to take home a very short message. I think it's very easy. It's the message that maybe all of you has in your own mind. Hypertension must be effectively managed and treated. The probability of a spontaneous improvement of blood pressure is very low. Drugs choice should consider the compelling indication for the different classes of drugs. The combination treatment is more suitable in high-risk patients. Fixed dose single pill combination can improve the management of hypertension, and available tools are more than adequate in the majority of hypertensive patients. And that's all on my side, and I thank you very, very much for your kind attention.